The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC, here with Inside JACC. And this morning I'm talking to Dr. Franz Messerli, and Dr. Messerli is on the cardiology staff at St. Luke's Roosevelt Hospital in New York. He's a clinical professor of medicine at Columbia University, and he's been the primary author of a very interesting paper we have in press that deals with the role of hydrochlorothiazide in the treatment of hypertension. And in this paper, Dr. Messerli and associates did a meta-analysis of the existing data on the efficacy in reducing blood pressure when given at a dose in 12.5 to 25 milligrams. And what they found in some 1,200 patients was rather interesting. They focused specifically on ambulatory blood pressure monitoring, and we'll ask about that in a moment. And what they found was, as compared to other antihypertensive agents, that the efficacy and magnitude of blood pressure reduction affected by hydrochlorothiazide in these doses was much reduced. In fact, as compared to a reduction in systolic and diastolic blood pressure of 6.5 and 4.5 millimeters of mercury, for instance, induced by hydrochlorothiazide, the ACE inhibitors reduced blood pressure by 12.9 and 7.7 millimeters of mercury. So very interesting findings. So Dr. Messerli, let me ask you first, why did you choose to focus on ambulatory blood pressure monitoring?
Actually, that's fairly simple. 24-hour ambulatory blood pressure monitoring is the most objective, thorough way to assess antihypertensive efficacy, and even the FDA has now recognized this. And so most drugs are now evaluated by 24-hour ambulatory blood pressure monitoring. As you may know, hypertension or blood pressure remains a surrogate endpoint. Nevertheless, you want to measure the surrogate endpoint as thorough as you possibly can. And this is why we looked at 24-hour ambulatory monitoring.
Well, it's interesting that you looked at blood pressure monitoring. Now, is it possible that hydrochlorothiazide had an efficacy on endpoints such as mortality and morbidity that in fact was greater than its efficacy on reducing blood pressure?
Actually, we did thoroughly scan the literature and look at that. The only studies that are available with hydrochlorothiazide were done in a much higher dose. As you know, Tony, at the present time, most doctors use 12.5 to 25 milligrams. Actually, when you look at the data, 99.9% of doctors use not more than that. And at that dose, there is absolutely no evidence anywhere that hydrochlorothiazide reduces heart attack, stroke, or death. So there are no good outcome data for hydrochlorothiazide.
That's a fascinating point, actually, that I took from your meta-analysis. Why do you think, given these facts, that hydrochlorothiazide has had such a prominent role? It's the most commonly used antihypertensive agent.
I agree with you. It's actually, there are 47 million prescriptions a year in monotherapy and about 87 million in combination. So a total of 135 million prescriptions per year in the United States alone. It's the most commonly prescribed antihypertensive drug, yet surprisingly no outcome data. The only outcome data we have with the so-called thiazides are with chlorthalidone and indapamide. Now, why we do not have good data with hydrochlorothiazide escapes me at the present time.
Well, very interesting. I was going to ask you that question, but you already answered, I believe, the fact that the data are a little bit more robust with chlorthalidone. I take it you would prefer chlorthalidone as a thiazide, and you would view hydrochlorothiazide at the moment as a second agent to be added on. Is that correct?
I think this day and age, we should really go by evidence and outcome. And since hydrochlorothiazide does have no solid evidence, we should, as you say, prefer drugs for which evidence is available, and that is chlorthalidone in the SHEP study, in ALLHAT, and in dapamide in HIWET. So if one uses or wants to use a thiazide diuretic, I think chlorthalidone or indapamide should be preferred.
Well, excellent information, a very nice study. I congratulate you. For Inside JACC, I'm Tony DeMaria.